Hello, everyone. This is the Gold Star Medical Business Services Billing School Boot Camp. This will be our class today. We'll be on credentialing and contracting. We'll be doing some training on this as this has become a very, very important topic to learn about within medical offices. Contracting and credentialing has become increasingly more complicated than it used to be, and so I want to make sure that everybody within our organization and any new billers learn the basics of credentialing and contracting. Credentialing and contracting can also be a very, very lucrative job because typically providers will pay more for people to do their credentialing for them since it is a very complicated and involved process. So let's go ahead and get started on talking about credentialing and contracting. So first of all, before we get into the nitty-gritty of the credentialing and contracting, let's just discuss how doctors or healthcare practitioners get paid. So this illustration that you see here on your screen basically shows you the flow of how a healthcare claim may be paid, and this really deals just with insurance payments. Of course, if a patient is a self-pay patient, it's going to be a little bit different. And we are talking about doctors and healthcare practitioners. So we're discussing professional claims here. We're not discussing hospital claims. And so if you're listening to this and you are a hospital biller, this is going to be different. But for professional claims, this is typically how the flow of a professional claim is going to work. So the first thing that happens is the doctor or HCP, and HCP stands for healthcare practitioner, will see a patient or treat that patient. And once the doctor or HCP has treated the patient, they're going to assign a code for that particular service. It may be an office visit, it may be an exam, it may be the patient may need sutures, the patient may need to have a diagnostic procedure done, but every one of these procedures or encounters has a specific code that is assigned to that encounter, and that's called a CPT code or a HCPC code. And of course, we have a lot of webinars and a lot of training on coding. This is not a coding class, so we're not really going to get into that in this particular webinar, but we will in other training sessions. So anyway, a code is assigned to the service, and that code is accompanied by a fee. So every code that is billed out by a physician to an insurance company has a value to it. And that value of that service is based on what we call the clinic's fee schedule. So the clinic basically has a menu of services that they will perform on patients, and each one of those services is assigned a specific code, CPT code or HCPC code, and each of those codes is assigned a value. Now that value is based solely on what the clinic assigns to be the cost for that service. All right, and that's important to know because it's not necessarily the fee that the doctor will get paid on, and a lot of that is going to depend on the credentialing and the contracting. So the next thing that happens is after that code is assigned and the value for that code is sent to the insurance company, it's billed out on a CMS 1500 claim form, sometimes on a paper claim, but most of the time this will be billed out in an electronic version of a CMS 1500 claim form. So it will be billed out to the insurance carrier or the insurance company. We'll use the word insurance company, the word carrier, and the words payer synonymously in this webinar. So sometimes I may refer to an insurance company as a payer or a carrier or an insurance company, but they all mean the same thing. Once the service is billed to the insurance company, it's then reviewed by that insurance company or a TPA, which is also another word for a third-party administrator. And later on in this presentation, I'll talk to you about what a third-party administrator is. So the insurance carrier or the TPA will review the services that were billed. They'll take a look at the patient's policy and whether the patient actually has coverage for that particular service or service code. And if they do, then they're going to look at something called a contracted or legislated fee schedule. And they're going to look at the contract that they, meaning the carrier, has with that physician, or if they have a contract with that physician. And if they do, then the contracted fee schedule will be applied to that service, and then the payment will be issued based on the patient benefits and the fee schedule. And so if the doctor is a contracted or an in-network provider, they're agreeing to accept the payment based on the insurance company's fee schedule, not based on what they billed. And as such, they are then going to be required to write off the difference between that clinic fee schedule and the insurance company's fee schedule. So it's very important to know that from the standpoint of, if you're a biller and you're going to be billing out claims and accepting when you receive those explanations of benefits back from the insurance carrier, you need to know whether your doctor is contracted with that insurance carrier, and if so, what those contracted fee schedule amounts are, and what the difference is between your fee schedule that you bill out and the actual fee schedule that the claims are processed against. So the question becomes, from a contracting standpoint, is whether, and doctors will ask me this all the time, is should I participate or not in this particular health plan? And there really is, in this day and age, very few insurance companies that do not work under the premise of managed care contracts. So you really do, for the most part, as a healthcare practitioner, have to decide on a case-by-case basis whether you are going to participate or not participate in a particular health plan. And there are a number of factors that will help you decide whether it is beneficial for you to participate or not participate in a health plan. The first thing that you need to look at are your patient populations. So think about the town that you practice in, or if you are a credentialing specialist within a doctor's office and they ask you the question, well, do you think I should go in network with this Kaiser health plan, or should I be in network with United Healthcare? Your question then to the doctor would be, well, what would be the benefit as far as patients go? Is there an employer in the area that employs, several thousand people, and this employer uses the Kaiser health plan or Blue Cross Blue Shield health plans to administer their group policies? Because if being in network with Kaiser or Blue Cross or Cigna or Aetna would give you access to that group, that population of patients, those 3,000 or 4,000 people that are employed by that particular employer in your area, would it be beneficial then for you to be in network with that plan so you have access to those patients? It's a very valid question. Sometimes you need to look at your patient population in terms of age or demographic or economic demographics. So maybe you're in an area in which there are a lot of low-income patients. And if that's the case, then you have to ask yourself the question, would I benefit from being in network with the Medicaid programs in this area? Because we have a tremendous population of patients who are on Medicaid or have some type of state assistance for their health care. Maybe you're in an area of the country that has a large, or in a town that has a large population of retired patients. And essentially, if you were not involved in the Medicare program, you'd be cutting yourself off from maybe 60% or more of the population. So it's really important for you to do your demographic studies, both from an employer standpoint, from an economic standpoint, and from an age standpoint, to see if it would behoove you to join certain networks or join certain types of plans. Now, the other thing that you have to look at when you're deciding whether to participate or not participate in a healthcare plan is the insurance carrier themselves and their contracts. And I always tell doctors and healthcare practitioners, if they're thinking about participating in a health plan, really the first thing, after they do their demographic studies, then they need to contact the insurance carrier and find out if they're even accepting new providers into the credentialing panels or the contracts that they offer within your community. Because if they don't, there's no sense in going through the long process of filling out the applications, sending it in, and then just getting a letter back from the insurance company saying, well, our panels are closed. We're not accepting new providers at this time. Find out ahead of time whether you are in a community or in an area that would be accepting new providers into these demographic panels that you would want to participate in. The other thing you would want to find out is whether the insurance company's products that are offered in your area are PPO products, HMO products, EPO, which stands for Exclusive Provider Organization products. And it's very important to know the difference, because under a PPO plan, it's not going to be as restrictive on the patients, meaning that the patient would have more of a choice of, if they saw an out-of-network provider, they still might be able to receive benefits, and we're going to kind of talk about that here in a little bit. An HMO plan could be extremely restrictive to you as a provider, and it may require that you obtain, especially if you're a specialist, that you obtain referrals for every single time an HMO patient needs to see you. You would have to get that referral ahead of time, and sometimes that can be a complicated and long drawn out process to where it would really restrict you from seeing your patients. You should look at the fee schedule. So, anytime you're doing a vetting of an insurance carrier's contract or product that they're offering in your area, ask them for a copy of the fee schedule. Look at your fee schedule for the particular service codes that you offer and see how it matches up with the fee schedule of that carrier. Okay? Because if you're expecting to get $100 for a certain service, and basically $100 is your break-even point when you're looking at it from the standpoint of your overhead and your practice costs and your administrative costs and your work time. But when you look at the fee schedule, they're only going to pay $75 on that particular service code. You may need to consider whether it would be worth being involved in that particular plan, or if the fee schedule is too low, is it negotiable? In other words, sometimes a carrier will offer a fee schedule, but that fee schedule can be negotiated. So you can actually tell the carrier, look, there's no way we can do this service for $75. We have to get at least $100 for this service. And you can show that, if you can show just cause as to why that is, based on your overhead costs and the economic demographics of your area, for the overhead, then you may be able to negotiate with that insurance carrier for a higher rate to that fee schedule that they initially propose. Sometimes the fee schedules are non-negotiable, but it's important for you to know ahead of time whether that is negotiable or not. The other thing you need to know under the insurance carrier contracts are what restrictions are there. In other words, if you perform a specific service on a regular basis, is this going to be a situation if you join that that plan that every time you perform the service, it's going to have to be pre-authorized. Or maybe that service is excluded from that plan altogether. In other words, like if you're a chiropractor, for example, and you look at a particular contract, and then when you investigate that contract, chiropractic services aren't even included on that contract. Chiropractic's not even paid for. Why would you bother filling out an application for that contract if chiropractic isn't even in? Chiropractic is not even included as a service under that contract. The other thing you want to look at in terms of the insurance carrier's contract, or what are the terms? Are you going to have to renew and reapply every year? Is this something that is perpetual, where once you're in forever? Are you going to have to revalidate every so often your information? Are they going to look at your claims usage and your claims volume from time to time and place you into a different tier level? And many insurance carriers now tier the physicians or the healthcare practitioners based on their claims volume and their compliance with the policy restrictions and so on and so forth. And sometimes you're placed in one tier, but the next year they have the ability to lower you down to a more restrictive tier. And so these are all questions that you would want to ask the insurance company before you decide to participate with that particular plan or that particular plan's product or contract. How do the carriers market you? Will they send a letter to all of the patients who are covered under that plan in your area, letting them know of your participation? Or is it simply going to be a situation where you're listed on their website as a participating provider? So you have to do your due diligence and fully research the insurance company and their contracts and products before deciding on whether to get credentialed and contracted with them. So the other thing that you really need to know is the ramifications of participating versus not participating when you're thinking about the plans that you wish to contract with. Now, you may look at a plan and you may think, gosh, the reimbursements are kind of low, but I've got about 3,000 or 4,000 people in my community that are covered under this particular plan. What would happen if I decided not to participate in this plan? What would the ramifications be? So let's talk about the differences between being a participating provider and a non-participating provider. So most of the time, if you sign a contract with an insurance company to be an in-network provider with that company and with that company's plan or their product, number one is you're usually agreeing to accept new patients, and many insurance carriers will not contract you if you're not accepting new patients. And also, if you ever get to a point where you stop accepting new patients, they may remove you from the panel because you're not accepting new patients. So be aware of that. Most of the time, under a managed care contract, you are agreeing to bill claims on behalf of the patient, regardless of the benefits. So the patient may have a $10,000 deductible, but you still have to bill on behalf of that patient. You can't just say, well, because you have a high deductible, we're just going to not bill your insurance and treat you as a cash patient. If you sign a contract with the carrier to be an in-network provider, you are agreeing to bill claims on behalf of that patient, regardless of the benefits. Now, there are ways to have patients sign a waiver to file insurance under some commercial plans, but we're not going to get into that in this particular training session. However, if you're listening to this and you want to know more about that, you can certainly contact me. But most of the time, if you're in network, you have to bill claims on behalf of the patient. You can't just give them a walkout statement and say, here, you have to bill your own claims. The other thing about being a participating provider is that you're agreeing to accept the payment based on the contracted or agreed upon fee schedule, okay, and you're agreeing to write off the difference between the billed fee that is coming from your office and the allowed fee that is agreed upon between you and that insurance company. Also, you agree to accept assignment. And what that means is that the healthcare practitioner is sending the bill to the carrier, and the carrier is going to pay you directly. And then if there is a remaining balance, that is collected from the patient on the allowable charges. And you also agree to follow the rules imposed under that contract. And those rules could be rules for pre-authorizations, for referrals, benefit limitations, and collections of patient balances. So basically, if you're participating, you have to know what your contract says, and you have to know that your contract, what it allows for and does not allow for. So what does it mean not to participate? Let's say you look at a particular insurance plan, or you've been contracted with a particular insurance carrier, and now they have a new product that they've offered this particular employer, and that product now is an HMO product. In other words, you used to be under a PPO plan with this particular employer in your area, but now they've gone to an HMO plan, and oh my gosh, it's just going to be so restrictive that you decide not to participate. So let's talk about what it means to not participate in a particular plan. With most carriers, if you do not participate in a plan, you no longer have to bill the claims. Medicare Part B is an exception to that, and some state Medicaid programs are also exceptions. And what this means is that you would simply give the patient a walkout statement. They would file their own claims. You don't have to accept a contracted fee schedule. All of the costs that are billed out are the patient's responsibility, so you can base all of your fees on your fee schedule. And for some physicians and healthcare practitioners, that's a big bonus. It's worth it for them to be able to charge the patient the full fee for service versus the negotiated rates that the carriers are wanting to impose on them. Some carriers, even though you do not accept a contracted fee schedule, some carriers will pay the claims back to the patient based on what's known as UCR, which is usual, customary, and reasonable fees for the geographic location. And what would happen is you would bill out your claim, let's say for $100. The insurance company would process the claim based on an allowable fee or based on the UCR of $80 and pay the patient based on the $80. It doesn't mean that you would have to write off the difference because you're not contracted. The patient would still be responsible for the difference between your billed fee and the UCR. So this is not a contracted write-off, but sometimes it confuses the patient because the patient looks at they receive an explanation of benefits from the insurance company after that claim is processed, and they see that you billed $100, let's say, but the insurance company only paid based on $80. And then they come to you and say, well, how come you billed me $100 and the insurance company said this is only worth $80? So it sometimes can cause bad blood between you and the patient when you are collecting based on your fee and not on the fee that the insurance carrier is saying is usual and customary. Now, you have every right to collect as an out-of-network provider. You have every right to collect based on your fee, but beware of the ramifications of what the insurance company is going to try to do. They're going to try to show the patient that you're overcharging. In their mind, anyway, in your mind, you're probably not overcharging for the service, but the insurance company may be telling the patient in their way that you're overcharging by showing them what that UCR fee would be. You don't have to accept assignments. So what that means is, as an out-of-network provider, you render a service and the patient pays up front for that service, and then receives their reimbursement, if any, directly from the insurance company. And that's kind of the upside of not participating, is it eliminates all the administrative requirements of you to file claims, and to go through pre-authorization requirements and so on and so forth. For the most part, there are some carriers that even as an out-of-network provider, you're going to have to do some pre-authorization, but that's generally an exception, not a rule of thumb. But the patient's benefits may be different. So in other words, if you're in network, the patient may only have to pay a $25 copay for their service. But if you're out of network, they may have to pay against an out-of-network deductible, let's say several $1,000s, before the insurance pays anything. And so because the patient benefits are different, their out-of-pocket costs are going to be higher. Sometimes there are no benefits at all if the patient sees a provider who is out of network. And it is important for you to notify your patients if there are no benefits as an out-of-network provider. They should be notified of that ahead of time, so they're not expecting to be paid and then receive a zero reimbursement back from their insurance company. It is up to the patient ultimately to know this. It is a contract between the patient and their insurance company, but guess who's going to catch the flack if you bill out a claim or the patient bills out a claim and was not informed that there were no benefits for that claim? I would say that even though it's not directly your responsibility, if you want to keep goodwill between you and your patients, you want to notify them of the difference in the benefit as an out-of-network provider. Most insurance companies, now here's a real downside with being out of network, is that while you have no obligation to bill the insurance company, they have no obligation to notify you of what they pay the patient, meaning you won't get an EOB, so you won't know if a claim has been processed or if a patient has been paid directly. And let me tell you where the danger of this is. The danger of this lies in if you provide the service to the patient but don't make the patient pay for the service up front. You tell the patient, well, when you get your insurance payment, you bring it to me and then pay me from that insurance payment. I would not recommend that you practice that type of a policy, because too often the patient will receive the payment and forget that they didn't pay you, whether they forget on purpose or by accident, they forget they didn't pay you. You don't know if the insurance company paid the patient yet. You won't be able to find out because you're out of network and the insurance company has no obligation to you. They're also not obligated to honor an acceptance of assignment. So some providers will try to process claims on the patient's behalf and accept assignment at the same time. If, for example, Medicare, you can be out a non-par provider with Medicare, you can accept assignment, and then Medicare will pay you directly. But some insurance companies don't honor that. You can decide between you and the patient, it's a Blue Cross patient, and you say, all right, well, I'll accept assignment even though I'm out of network. We'll go ahead and bill your claims for you. But the insurance company does not have an obligation to accept that. They can still go ahead and pay the patient if they want to. So be aware of that and be aware of the insurance plans in your area. If you decide to be out of network, make sure that that plan, if you decide to go the route of accepting assignment and billing for the patient as an out-of-network provider, make sure that that insurance company will indeed pay you directly and not pay the patient, and that you will receive notification of that payment. Because if you don't, then you're sort of swimming in the dark, because your patient will not pay. They'll receive whatever reimbursements they may receive from the insurance company, and you're not going to know when and if that even happened. And now you're having to chase after a patient for a dollar amount for those services that has never been paid for to you. So be aware of that. The other thing is most insurance companies are going to discourage patients from treating with a non-par provider. The insurance company wants the patient to see providers who are in the network. And so if you leave a network or disenroll from a network, the insurance company will definitely write to the patient and encourage them to seek out a participating provider. You will no longer be listed, or you'll never be listed on the insurance company's website under the provider search tool. So if a patient in your area is looking for a provider, they're not going to find them by going to that insurance carrier's website. So be aware of these ramifications of not participating, and you're going to have to assess whether it is worth it or not to participate or non-participate. So let's talk a little bit about some semantics here. Many people get credentialing and contracting mixed up, or they don't know the difference. And most people view credentialing and contracting as the same thing, but they're definitely not the same. So here's what credentialing is. Credentialing is gathering information needed and submitting the healthcare practitioner's credentials to an insurance company for consideration under the various contracts that insurance company's umbrella offers. This is the first step to contracting. So just because a healthcare practitioner is credentialed with a carrier doesn't mean they're participating with all of the available contracts. And I see this happen all the time. We at Gold Star Medical, one of the divisions that we have is an outsourced medical billing company. And so many times we will take on a new client who is a provider, and they're having difficulty getting paid by Blue Cross Blue Shield. And what we do is we go in and we investigate for them, and we find out that while the doctor was credentialed as a participating provider with Blue Cross Blue Shield of, let's say, California or Ohio or Texas, they were only contracted with the PPO plans that were offered in their area. They were not contracted to provide services under the HMO plans. And they were denied, and all of a sudden, one of their employers made a change at the beginning of the year from a PPO plan to an HMO plan. And now, all of a sudden, their Blue Cross claims aren't getting paid because the doctor is not contracted with that HMO, even though they are credentialed with Blue Cross. So you see the difference. When you do contracting, that's where you're deciding on which contracts or products under an insurance company's umbrella you are going to participate with, and then applying for participation in each of those individual contracts. Now, most of the time when you do contracting, you're not going, the insurance company may have 7 or 8 different products in your area, and usually what will happen is you will apply for the PPO contracts and for the HMO contracts, and there may be 4 PPO contracts and 3 HMO contracts, and one application will cover all 4 of those contracts. So just because you have many different products under one carrier's umbrella, it doesn't mean that you're going to have to do 7 or 8 different applications. It's really going to depend on the insurance company themselves and what their rules are for contracting. The question always comes to me, very, very often throughout the year. I'm going to have healthcare practitioners, doctors ask me, should I or should I not participate in Medicare? And I'm talking about Medicare Part B now, which is considered original Medicare and considered to be the Medicare part of Medicare that handles physician services. Okay. So most healthcare practitioners have 3 choices when it comes to Medicare. They can enroll as a Medicare participating physician, as a non-participating physician, or they can choose to opt out of Medicare altogether. Now, here are the differences. If you are a participating or what we call a PAR provider with Medicare, that means that when you see a Medicare patient, you are going to bill out the claim for services, you're going to accept assignment of those claims, and you're going to follow the participating provider fee schedule for those particular services, and you're going to follow what is called the LCD, or the local coverage determination document, for billing and reimbursement of that particular service or type of service. If you're non-participating with Medicare, you are still required to bill out claims for the Medicare patient. Now, you can choose to accept or not accept assignment, and you will have a different fee schedule, and you will also be subject to what is known as the limiting fees under the fee schedule. And if you have any questions at all about what are the non-par fee schedules, what are the limiting fees, and so on and so forth, please feel free to contact me about that. Again, in this particular webinar, we're not going to have time to go into the differences between the participating, non-participating, and limiting fee schedules. You will also be required to follow the LCD. So really, the only difference between a par provider and a non-par provider for Medicare is whether you accept assignment or not, and what the reimbursement is going to be under the Medicare fee schedule. You're going to have to follow the same billing and reimbursement rules as a participating provider. Now, if you choose to opt out of Medicare, that means that you are not going to accept a Medicare patient for billing claims. In other words, you can see a Medicare patient, but if that Medicare patient decides to see you as an opted out healthcare provider, they're going to become a cash pay patient. They'll have to be self-pay. Medicare will not be billed. You'll charge your self-pay rates, and that's all there is to it. Medicare is not billed. Now, there is a group of providers who are not allowed to opt out of Medicare, and these are chiropractors, anesthesiology assistants, speech-language pathologists, physical therapists, occupational therapists, and any specialty not eligible to enroll in Medicare, such as a massage therapist, acupuncturist, or naturopath. They can't even enroll, so because they can't enroll, they can't opt out. But chiropractors, and especially chiropractors and physical therapists, speech-language pathologists, anyone on the list that is shown on this particular slide may not opt out of Medicare. So what does that mean? If you can't opt out of Medicare, but you don't want to be involved in Medicare at all, you don't want to bill Medicare claims, what that means is that if you are unenrolled in Medicare and you decide not to enroll either as a participating or non-participating provider, you may not accept or treat Medicare patients, period. You would have to refer anybody who has Medicare out of your practice, and that includes established patients who age into the Medicare program. So, you may think, oh, well, I have a very young population of patients. We get very, very few Medicare-aged patients in my community. I don't see very many Medicare patients, and I have no problem referring any Medicare-aged or Medicare-eligible patient out of the practice. But what happens as you are in practice longer and longer? Now you have long-time faithful patients who become Medicare patients. When is that going to happen? And how soon is that going to have an impact on your practice? So it's not recommended for practitioners who cannot opt out to refer patients out. You should enroll in Medicare, either as a participating or a non-participating provider. And if you wish to just get your fees up front, then enroll as a non-par provider. Bill out the claims for the Medicare patients. Don't accept assignment, and let Medicare deal with the patient directly. But don't just not enroll, because if you are one of those providers who cannot opt out of Medicare, like a chiropractor or a physical therapist, and you accidentally see a Medicare patient, and that Medicare patient accidentally decides to bill Medicare for their services. They think, well, I know the doctor said that I'm just going to be a cash patient, but I'm going to try to bill Medicare anyway. And Medicare receives a claim from a patient, and they don't have you as an enrolled participant with Medicare. You could face fines of upwards of $11,000 to $30,000 per incident. So this is a very, very serious violation. It's not somewhere that you want to go. And so if you are listening to this and you're thinking about credentialing with Medicare, I would say that unless you clearly know you want to opt out and are eligible to opt out, then you need to decide if you're going to enroll in Medicare as a participating or a non-participating doctor. Medicaid contracting is another bird altogether, and it is one of the most complicated programs from a contracting and reimbursement standpoint because you have a lot of different moving parts. Number one is you have the state Medicaid program. Now, this is the general Medicaid program of each state. And the state Medicaid program will provide the general billing and reimbursement guidelines for different types of medical services, very similar to the LCDs that CMS offers practitioners for different types of services. Some states, it's very straightforward. You will submit your claims to the state Medicaid program, okay? However, more and more states now, many and the majority of the states in the U.S. now contract with various commercial carriers to process and pay claims. And they have different products. They have HMO products, PPO products, and so on and so forth. And Medicaid patients can be assigned to a particular managed care product and then switched to another one the next month, because Medicaid is a program that is revalidated from month to month because it's based on income. And so the Medicaid system has the ability to take a Medicaid patient who may be under, let's say, a Blue Cross managed care Medicaid product, and the very next month move them to a Cigna HMO product. And as such, what that means is if you don't contract with every Medicaid managed care plan in your state, you could be treating a patient in network one month and out of network another month and have no benefits for that patient, especially if they move the patient from a PPO plan to an HMO plan that you're not contracted under. So you have to do your due diligence when it comes to researching state Medicaid programs in which you want to participate. And if you're a credentialing specialist and you're listening to this class, and the doctor is asking you to do this research, you need to know every plan that your state Medicaid program has under their umbrella, every contracted plan, and what the requirements are, what the reimbursements are, and and you're going to have to discuss those with your healthcare practitioner and help them decide if they would like to get contracted with those plans or not. Under the commercial payers, which are your patients who are basically working age patients, and they have an insurance plan through their employer, or they have individually purchased insurance. This is the Medicare patient or a Medicaid patient. It's important that you research for payers that have contracts in your area. Look at the major employers. Maybe one of the things that I used to do when I was extensively doing contracting and credentialing on behalf of doctors is I would contact the Chamber of Commerce of a particular town that doctor would practice in, and I would ask them for a list of the major employers in the area and how many employees they have, and then get the telephone number to the HR department and find out who they have as their insurance carrier for their employers. The other thing that I would look at are the healthcare marketplace products that are available in your area and for your particular state or your particular region. And the healthcare marketplace refers to products that are under the Obamacare plans or the PPACA, Patient Protection and Affordable Care Act plans. So once you have researched the payers that have contracts in your area, then you're going to apply for credentialing if you haven't already done so, and then apply for the contracts under which you wish to participate. The other thing you have to do is, under the commercial payers, is make sure you're keeping up with the changes in employer contracting. So, you may be contracted with Blue Cross Blue Shield because the local Honda plant has Blue Cross Blue Shield as their carrier, but next year they have renegotiated with Aetna, and now they're going to be covered under an Aetna HMO for the next calendar year. And if you don't keep up with those changes and find out ahead of time from the employer's HR department that a contracting change is going to be taking place, you won't know to apply for those contracts and be ready when those contracts change. So find out if they're going to switch to a new carrier. Find out what the terms of the plan are going to be, and see if it's worth it for you to be in network with that plan. And make sure that if it looks like they're moving to a plan that is going to be very detrimental to your practice and even to their patient, to their employees. So, think about it if you're a specialist, a dermatologist, for example, or a chiropractor, and you find out that they're moving to an HMO plan that is very, very restrictive in their benefits. Or maybe they don't even cover chiropractic anymore, or they don't cover certain cosmetic procedures under dermatology that were covered under the old plan. And you know that it is going to really affect your patients and the employees in general. Let those HR people know the ramifications of that all of a sudden they're going to have 3,000 employees who no longer will be able to receive chiropractic benefits. And make sure, if you don't find this out ahead of time, encourage the employees to notify the employers that these benefits have been really restricted, or the plans that have been, now they've moved to a new plan that's extremely difficult to work with. Make sure that those employees give their employers the feedback on that, so that the next year when it comes up for renegotiation, they can look at either changing plans, enhancing the plans to get that benefit back, and so on and so forth. Because remember, most of the time when you're dealing with employer-sponsored health plans, you typically only have to deal with that plan for a year at a time. And if they're great plans, then obviously you hope they won't change. But if they're terrible, you have a year in which you can make your case and encourage them to change plans or enhance their plans to include the services that you offer. The other thing that you have to be aware of is that sometimes a health insurance company or a payer will contract with a third-party administrator, and a third-party administrator is not an insurance company. So one of the things you need to know is that a third-party administrator is like a subcontractor to an insurance company, and they will be contracted by the insurance company to take over certain functions of claims processing. They may be responsible for pricing the claims or setting the fee schedules. They may be responsible for benefit and claims reviews and claims adjudication. They may be responsible for submitting and processing requests for pre-authorizations and predetermination of service. And they may also be responsible for establishing case management of a patient or peer reviews of different types of claims that are being submitted through that third-party administrator. Now, the thing to know about the third-party administrator is that a provider, if they are in network with an insurance company that utilizes a third-party administrator, if they wish to receive in-network benefits, they must additionally be contracted by that third-party administrator that provides claims management services on a carrier's plan in order to be considered in network with that plan. So, for example, the healthcare practitioner might be in network with a Blue Cross Blue Shield PPO, But because that PPO is administered through, let's say, a third party, a common one is American Specialty Health Network. An American Specialty Health Network is responsible for administering that particular Blue Cross PPO. If you, as the healthcare practitioner, are not contracted with ASHN, American Specialty Health Network, you will be considered out of network with that Blue Cross plan, even though you originally contracted as an in-network provider. It's crazy, but it's true. And these are things that you need to know when researching the contracts under which you wish to participate. You have to determine whether a TPA is involved. The other thing you need to know about these TPAs is that they take a cut of their pie. I mean, they don't do this for free. And so what it oftentimes does is it cuts into your reimbursements even further, and you'll usually find that an insurance company that is using a TPA is going to have a much lower reimbursement threshold than if you're dealing directly with that insurance company. It could be as high as a 10 to 15% reduction over and above the contracted fee schedule with the carrier. So be aware that the TPA may assess what's called an administrative fee, or they sometimes build the cut right into the fee schedule that the TPA offers. So just be aware of all of that when you're looking at contracting, and the contracting may involve a TPA. So the question that I'm asked oftentimes is, when do you need to do credentialing or contracting? So these are the criteria that might prompt a credentialing application or a contracting application to be initiated. One is if you're newly licensed. So you've just come out of medical school and you now are about to enter into practice as a new physician or a new healthcare practitioner. Maybe you're starting your own clinic. You were working as an employee under a large organization, and now you've decided to branch out on your own and start your own clinic. So you're going to need to be contracted under all of the plans individually that are within your geographic area. Maybe you're going to work for a new clinic or a new doctor. You're going to work for them as an employee. You may need to be contracted under that clinic's contracts, or credentialed under that clinic's contracts in order to be able to provide services as an employee of that group. Maybe you're a solo practitioner, and now you've decided that you need to hire associate practitioners like a nurse practitioner or a PA or an associate doctor. And instead of billing everything as an individual practitioner, you're now going to bill everything under a group. So you're going to have to do a whole credentialing as a group, and then have all of the associate practitioners contracted with that group under that big umbrella, under that group credentialing umbrella. Maybe you're moving to a new location. You're contracted with an insurance company, but now you've moved and you need to update your information. Even if you're moving down the street, or I've seen even if you're moving within the same building to a new suite, you need to update your credentialing. It's extremely important to do so. Sometimes geographic locations are so densely populated that if you move down the road from your current location, you're in a new zip code, and it could be that that new zip code isn't accepting new providers. So it's very important to know what you're getting into when you move to a new location and what the requirements are going to be. I've seen many, many, many times practitioners who move to a new location don't take care of the updates to their credentialing, and all of a sudden the insurance companies stopped paying the claims because they will not forward payments to a new location. Those checks are going to go back to the insurance company. So there are things very important steps that need to be taken if you're moving to a new location when it comes to credentialing and contracting. Maybe you're moving into a new state and you're going to set up practice in a new state now. Or maybe you're going to open up a a group of clinics, and those clinics are not going to be located in just one state. Maybe you're going to have clinics in Texas and Oklahoma and Colorado and Arkansas, and you need to know how to set up the credentialing for that multitude of clinics. Maybe you're setting up a new corporation. You were a solo practitioner, and all of your credentialing was applied for under your individual numbers, and now you're going to set up a new corporation because you want to hire new doctors. You're going to have to set up credentialing for that corporation. Perhaps your insurance company is requesting contract renewals or revalidations, or they're requesting that you reattest to the credentialing. All of these scenarios could prompt you to do a new or updated credentialing or contracting application. So now that you've decided that you've done your due diligence, you have researched the contracts that you wish to apply for credentialing on, and now you're ready to get started. So the question is what information do you need to get started with a credentialing and contracting application? And so we're going to talk about the minimum, the bare minimum information you're going to need to have. And then we're going to also talk about some additional information that insurance carriers may ask you to provide them with. So minimum, you're going to need a social security number or an employer identification number, also known as a tax ID number. If you are an individual practitioner and you're billing as a solo doctor, I always recommend that you apply for an EIN even as a sole proprietor or a single member LLC. You would want to apply for an EIN versus billing under your social security number, and it's really for protection, for your own protection, because your social security number then shows up on claim forms and other places where you really don't need to be disclosing that. So I would recommend that you apply for an employer identification number through the IRS if you don't already have one for yourself or for your organization. The other thing you're going to need in order to do any kind of credentialing is an NPI number, and an NPI is a National Provider Identifier. There are two types of NPIs. The type 1 NPI is an individual NPI. This is your permanent NPI that is assigned to you as a provider. You will only receive one individual NPI in your lifetime, and your NPI follows you wherever you go. So you can move from one state to another, you can move from one clinic to another, and your individual NPI will always remain the same, okay? If you plan to be a solo practitioner and you don't ever want to hire anybody to help you out, you just want a little mom and pop clinic where you're providing the services, it's you and an assistant or you and a nurse and a biller, and you're in a little rural town and you really don't ever intend on growing the practice beyond what you personally can do, then you can apply for your credentialing under your type 1 individual NPI. However, if you plan to have a practice in which the claims or the insurance payments are sent or funneled to your organization or through your corporation, through a corporate entity, you're also going to have to apply for an organization NPI. And this is more typical. Most of the time, a provider, unless you are going to be an employee for the rest of your life and you're not going to open up your own clinic, then you would only need a type 1 individual NPI. But if you're going to open up your own practice, if you're going to, even somewhere down the road, hire an employee that will be billing under your practice as well as yourself, like an associate doctor or nurse practitioner, you would want to apply for a type 2 organization NPI. If you want all of your claims paid to a corporate tax ID, regardless of how many providers, you need a Type 2 organization NPI. And an organization NPI belongs to the corporate entity. And so that may change. So you may have, for example, you may have 5 different clinics, and each clinic is set up as an individual LLC. You would have a Type 2 NPI for each one of those clinics. Okay, and so really and truly, one of the things that you would want to do if you are going to be dealing with multiple clinics is really get with a healthcare attorney that handles the setup of a corporate structure of a multiple facility healthcare clinic to decide how you want to set up your NPI structure and your tax your tax ID, your tax IDs, and so on and so forth. Now, to apply for an NPI, it is a very simple process. Honestly, it takes about 15 minutes to apply, and it takes about 20 minutes to get an NPI, even though it says it'll say on the application that it could take several weeks to receive one. I've never seen one take more than 24 hours. It just doesn't happen. And so what you're going to have to do to apply for an NPI is go to the NPPES website from CMS.gov, which is Center for Medicare and Medicaid Services. Establish a login, and typically what you'll do is you will establish a login and a password to an entity called the CMS Identity and Access System. So if you just go to Google and do a search for CMS Identity and Access, it will take you to a website that will allow you to establish a login and a password. That will get you into both the database to apply for an NPI and the database to apply for a Medicare number. And so you definitely want to go through the CMS INA system so that you have one login for both systems. And it will keep things much simpler from the standpoint of remembering, what the logins and so on are and so forth. Make sure you decide up front if you want to credential as an individual, as a corporation, or both when you are deciding to do your credentialing applications. This is just a snapshot of the NPPES login portal, and you can see where it has registered users sign in. And if you look to the right of the sign-in screen, it says create a new account, and it says here you need an identity and access management system, INA, user ID, and password to create and manage NPIs. And so, and then it will state if you don't have an INA account, need to update your existing INA account, or don't remember your user ID or password, select the Create or Manage an Account button below to go to INA. So before you can apply for an NPI number, you would need to create an INA account. And this is essentially at this point in time, what the website looks like. Now, remember, this is January 2018. Websites can change, their looks can change. So if you're we're going to have this up in our library archives for training, maybe 2 years from now that you're listening to this, and so this may look different 2 years from now. I don't know, but this is what it looks like as of January of 2018. So the minimum information that you're going to need to get started, in addition to a tax ID number, social security number, and an NPI, are going to be the following. You're going to need a copy of a current and valid license to practice your medical specialty in your state. A physical location where you'll practice. Most insurance companies will not credential you until you've secured a physical location. So if you're thinking about moving to a new state, for example, and you wanted to get a jump on credentialing, you probably are not going to be able to do anything until at the very least you have signed a lease with or purchased a building and closed on that building before you can start the credentialing process. Copy of malpractice insurance declarations page. So every entity that does credentialing and contracting needs to know that you have active malpractice coverage. Under the and one of the things that you need to know for malpractice coverage, I get the question all the time of how much coverage should I have. 78% of the insurance carriers for credentialing purposes require a minimum of a $1 million per claim, $3 million per aggregate in liability insurance. So they want $1 million, $3 million limits. Just so you know, if you're thinking about, okay, I'm going to buy a policy with 300,000, 600,000 limits, you may not be able to get credentialed with those limits. They may tell you that you have to go up to a higher limit in order to be credentialed. Copies of any special licenses and certifications. So if you are going to prescribe medications, you're going to need a license through the Drug Enforcement Administration. CLIA is for the Clinical Laboratory Improvement Act. If you're going to do labs in your office, you may have to get a special certification for that. And also, you'll need to know what your start date is going to be. So if you have a starting date that you wish to start practice, you'll need to let your credentialing specialist know what that start date is. If you're going to go work for someone else, you're going to need an individual NPI and all of the information that I just gave you above, plus you're going to need to know the Type 2 NPI and tax ID of your employer. So if you're looking to add yourself to an employer's already existing credentialing, that's the information that you're going to need either as a credentialing specialist or as a new employee. Other documents and information that you might need in order to get started with a credentialing packet would be copies of your diplomas from your medical and undergraduate schools that were attended. Some insurance companies require you to upload copies to them of that. They need your citizenship information. Most of the time they ask you if you are a U.S. citizen, and if you attest to the fact that you are, they don't ask for anything else, although I have seen some insurance companies ask for a copy of a valid driver's license, passport, and so on and so forth. If you are not a citizen, they may ask you for a copy of your Social Security card as proof of your citizenship information, or if you're not a citizen, they may ask you for a copy of a green card or a work visa. You're going to need to provide key dates to the insurance companies that you're contracting with. That includes your birth date and the city and state or country in which you were born, the date you graduated from medical school, the dates attended, the dates you graduated from high school and undergraduate school in many cases, the date you saw your first patient or will see your first patient, the date you saw or will see the first patient at your current or new location, and if you're moving, the date you saw the last patient at any of your old locations. If this is a new employment, the date you terminated employment with the last company that you worked for. So all of these dates are going to be very important to provide to the credentialing person who's handling the credentialing on your behalf. You'll also need to provide the insurance companies IRS forms that validate your company name and employer identification number. This is known as a CP 575 form, and you can get that from the IRS. If you are enrolling or credentialing as a group, you're going to need proof of ownership of the corporation and the managing and how much managing control you have of that particular corporation. So you may need to provide articles of incorporation. Some carriers require certain forms that you have to fill out for proof of ownership, and so on and so forth. You also will need to provide, if you have any of this, you'll have to provide the insurance company information on any adverse actions that may have been taken against you or your corporation, and that includes dates and details. Every credentialing application is going to ask you if you have had adverse actions against you. This would include misdemeanor or felony convictions, and it may specify even if the charges were dropped, it may tell you that you have to disclose that. Malpractice suits or malpractice complaints that were brought against you, even if it didn't result in a malpractice suit, and what the disposition of those suits or complaints were, and if you've ever been excluded from any insurance plans, whether you were kicked out involuntarily or voluntarily withdrew from those insurance plans, or if you were ever excluded from the Medicare program or from any federally funded programs. Now, I'm just going to tell you, docs, be honest about this. I have done credentialing applications where, you know, we query the providers about these types of adverse actions, and they answered no to everything, that they've had no adverse actions. And this actually just happened 2 or 3 days ago, where we received a letter on behalf of a credentialing application that we did for our provider. It was a brand new provider, and they just moved to a new state, and they were turned down because they were in the process of having their license revoked, their license to practice revoked. And they didn't disclose that to us, and so they paid us a lot of money to do this credentialing application, and maybe they were hoping that we could push it through, but the insurance carriers have ways to find all of this out. And so just because you say no doesn't mean they take your word for it. They will vet those questions, and they will investigate, and they will find out whether you have been excluded from any programs, or if you have any convictions or suits that have been brought against you. So please be honest with us about it, because your credentialing specialists don't want to waste time and money on a situation in which you may not be able to get recredentialed. Maybe you were kicked out of a plan, and you have a 2-year waiting period before you can reapply, and you haven't been within that 2-year waiting period. Let your credentialing specialist check on that for you to see if you need to wait on a particular contract before you start applying. The next thing that I'm going to strongly recommend is that, if at all possible, use any and all online enrollment tools at your disposal for your applications if they're available. Most insurance carriers nowadays allow you to enroll and do your credentialing applications online. And if I tell you, in the old days, this was a huge problem. We would go to an insurance company. We might even be able to go to their website and download the application for credentialing, fill it all out on paper, make copies of it, send copies, and a few weeks later call the insurance company, and they say we've not received it, or we're missing this information. And then we send the information in, and they say they still didn't receive it. And it becomes a very, very, very frustrating process. Nowadays, you can do your applications online. You can receive immediate confirmation that the applications were received. You can upload the documents directly to the insurance company versus mailing them and risking them being lost. So if you have to send supporting documentation, you can upload the supporting documentation. So make sure whoever is doing your credentialing for you, or if you have a credentialing company, that they are utilizing the online tools at your disposal and at their disposal to do these credentialing and contracting applications. The first website that I want to bring to your attention is called the CAQH ProView. Now, this is formerly known as the Universal CAQH UPD, or Universal Provider Data Source. This is an online credentialing database. It is considered a universal credentialing information receptacle and database that is used by many payers to gather information up on a provider. It keeps all your information secure in one place, in one centralized database. Payers will access this information to process applications for credentialing. Some payers only require the information from CAQH. In other words, if you contact a payer and say, I would like to be enrolled in your contract, they'll ask you, do you have a current CAQH database or a current CAQH profile? And if you do, they will get that information from you on what your CAQH number is, and they will simply go in there and credential you based on the CAQH. So this is one of the very first things you need to do when you are getting credentialed, is to have a CAQH profile set up. If you have already done this, then it is vitally important that you keep up with it. CAQH requires you to, excuse me, CAQH requires you to reattest every 90 days. So you'll get once you've enrolled in CAQH and you have your provider profile set up, be as detailed as possible with that profile, okay? Make sure you upload all your supporting documents to the CAQH database, because it makes it easier for you to retrieve in the future. Plus, again, the payers can retrieve that supporting paperwork from the CAQH database. And when it comes time for you to reattest, all you'll have to do is make sure that all your paperwork is current. So, for example, if you have a copy of a license, your state license in there, and the license has expired, then you can delete that one and reload your updated license. So you always have the most updated information in that database. And the login is provided here on this screen. One of the very first steps to credentialing should be to fill out, if you haven't already done so, a CAQH application. And when we do a credentialing for a provider, that'll be one of the first steps we do, is to determine whether the provider has a CAQH application, and if so, is it up to date? Many times we'll take over credentialing for a provider and we find out that yes, they do have a CAQH application, or a CAQH profile, but it hasn't been updated in 3 years, and so everything is outdated. There's incorrect addresses in there, and so on and so forth. And it's very, very important to stay up and stay current with the CAQH profile. This is what the login looks like for the CAQH database. And again, it gives you a whole bunch of videos that you can watch to teach you how to get started with CAQH ProView, how to log in for the first time, what to do if you forgot your username and password, and so on and so forth. So make sure that you make yourself familiar with the CAQH ProView website, and that you have a current login and password and CAQH number for future credentialing operations. For Medicare enrollment, the first thing you're going to have to do is enroll, again, as I said, when you do the NPI application, you have to enroll in the CMS INA, the Identity and Access Management System, to apply for both an NPI number and to apply for Medicare PTAN number. And PTAN stands for Provider Transaction Access Number. You can't do any business with Medicare without a Medicare PTAN number. You can't even check a claim status. You can't bill claims or anything without a Medicare number. And so after you have gotten your CAQH profile done, the next step is to enroll in Medicare. Unless you are absolutely certain that you're going to be opting out of Medicare, this would be the next step to take in the credentialing process, is to enroll in Medicare. And so this is basically a sign-in that gives you access. You can create a new account to create access to both the PACUS, which is the Medicare Enrollment Application Database, and the NPPES, which is the National Provider Identifier and Enumeration System. This is the home page for PACUS, and this is what this would look like once you have gotten your INA access. Then you can go to the PACUS enrollment and you can begin to fill out the Medicare application. It is a very, very intuitive application. You can enroll in Medicare Part B. You can enroll as a Medicare DME supplier. And what will happen is once you have logged in to this provider enrollment portal, you'll be given a little questionnaire, and it's going to ask you, are you a sole proprietor? Are you enrolling as a group? Are you an employee of another doctor? And so based on the answers to those questions, it will direct you to the correct Medicare enrollment form, because there are a number of different forms that you can fill out. And in years past, one of the biggest obstacles to Medicare enrollment was filling out the wrong form. You were supposed to fill out, an 855I instead of an 855B, or an 855R instead of an 855 DME. And so you need to make sure that you follow all of the questions and you answer as truthfully as you know how the answers to the initial interview or questionnaire, so that you can be directed to the correct Medicare enrollment. And if you don't have the answers, if you're a credentialing specialist and you're listening to this and you don't have the answers to some of the questions in the interviews, then stop and contact your provider and find out the answers to those questions before you proceed any further and risk filling out an incorrect application. Now, if you're once you enroll in Medicare, if your provider chooses to participate in the Medicaid programs, then it will be important and imperative actually for you to go to your state Medicaid website in which you're practicing. Look for the provider portal or provider enrollment support center and download any instructions they give you on how to enroll as a Medicaid provider. And again, most state Medicaid programs do have online application capabilities, although I will say that of all of the insurance carriers, the Medicaid carriers are the most behind the times in online application capabilities. I've seen vast improvements over the last 2 years, but even as soon as a year and a half ago, there were still state Medicaid carriers, and there are still some state Medicaid carriers that do not have online provider enrollment. And so it is imperative, if you are doing a paper enrollment for Medicaid, that you follow the instructions they provide you to the letter. Make copies of everything you send everything certified mail to ensure that they've been received, and make sure that they are going to the right address. So, and the other thing is, you have to be sure to enroll in all the Medicaid programs or contracts under which you could possibly be seeing patients. And so Medicaid, if you're a credentialing specialist, you will more than likely spend the majority of your time enrolling Medicaid because of the vast complexities of Medicaid enrollment. Here's an example of the Texas Medicaid website. So if I did a Google search, I typed in Texas Medicaid providers portal, and this is where it took me. And so you'll see that there are a number of different links that you can then click on to find out how to enroll as a Medicaid provider under Texas Medicaid. And it gives you several different places that you can go to. And my recommendation is anything that says enrollment, you check out to make sure that you've gotten all of the steps necessary. So you can see that they're right here. There are maybe 4 different places that you can go to find out more about Medicaid enrollment and contracting for state of Texas Medicaid. And of course, every state is going to have a different website, and you will need to know how to navigate that website and the online enrollment process in order to get that contracting done in as efficient a manner as possible. For commercial payer enrollments, this is going to be on a payer by payer case. So you cannot just say, well, CAQH is going to enroll all of my commercial payers. That is not the truth. You'll have to go first to each of your payers' websites. So if you're going to enroll in, let's say, Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, and Presbyterian or Kaiser, then you'll want to Google each of those websites, the provider portals for those websites, and look for any and all information you can get on the provider enrollment process. So, there is no way that I personally could individually train a credentialing specialist on every aspect of credentialing for their state. A lot of this is going to be successful for you based on the diligence of the research that you do. Okay, so make sure you do your research before you just jump in and start filling out applications. Follow the instructions carefully on how to do the credentialing and the contracting per the payer's website, even if it means taking a screenshot of those instructions and copying it to a Word document, so that if for some reason it doesn't go as expected, you can appeal a credentialing application based on the instructions that were given to you on that website. Okay, every payer will have different enrollment instructions, and of course many of them will require, before you do any enrollment with them, to have an updated and completed CAQH profile. So this is an example of a provider portal for Anthem Blue Cross, and this particular portal covers the states of Ohio, Kentucky, Indiana, and Wisconsin. So if you are a provider in any of these states and you did a Google search for Blue Cross Blue Shield of Ohio provider portal or provider enrollment, then it would take you to this portal, and then you can go from there on obtaining the specific directions on how to do your contracting applications. So I always get a bunch of questions about enrollments and applications, and one question that's very common is, how long does it take to do a credentialing application? And what I have seen is that if you have all the information needed, in other words, you don't have an incomplete database, and you have all the questions answered, and I'm talking to credentialing specialists now, because as a credentialing specialist, you're going to have to obtain all the information needed from that application from your provider. Okay, now some of it you could get from maybe a CAQH database, but if the data is out of date, then you're going to have to query your providers. And Gold Star Medical, when we do credentialing for our doctors, we have a credentialing questionnaire that they are required, that each provider who wants us to do credentialing for must fill out in order for us to proceed with their credentialing applications. And it asks all of the questions, and it gives the providers all of the documents that they would need to upload. And that usually gives us about 95 to 99% of all the information we need to do a credentialing application. Now, once we get that, it's just a matter of finding out which applications to do, what the process is, and then filling in the blanks and submitting the applications and uploading the documents. At that point, once we have all the information gathered up, it should take between 30 minutes to an hour for each application, for each online application. It's going to take longer for applications that are done by paper, of course, but between 30 minutes to an hour to complete and a credentialing application. And and sometimes it doesn't take that long. It doesn't even take 30 minutes. Sometimes it takes longer than an hour. It really depends on the complexity of the application itself. But 30 minutes to an hour is what you might plan. So if you have a credentialing company and they're like Gold Star Medical, we charge doctors to do their credentialing by the hour. So if you think that you're going to want us to do, let's say, 5 credentialing applications, then as long as you've submitted all of your information to us and it is accurate and we have everything we need to plug into these applications, then 5 applications, you can estimate between 4 and 5 hours to do those applications. And then you would know based on our hourly fee how much that might cost you to have us do those applications for you. But it's not just a matter of the applications. Once the application is done, then you're and received by the insurance company, then it is going to go through a vetting process. It's going to go through what they call the credentialing process. And this is where they are going to look at all of your questions and they're going to validate that information. The average time that it takes for a credentialing or a contracting application to be approved is about 90 days. That's on the average. I've seen Medicare, you can, in certain Medicare, in certain states, a Medicare application could take as little as 30 days and as long as 120 days. It really depends on the state, the volume of applications that are being submitted. I will tell you that the end of the year and the beginning of a new year usually will be the longest wait times, because this is when physicians are enrolling in new plans or disenrolling in old plans, and so the volume of contracting it spikes significantly in the fourth quarter of each calendar year. And so be prepared for longer processing times if you're doing your applications in October, November, December, and even into January, because of the greater influx of applications. An insurance carrier can usually give you an estimate, and they're always going to give you an estimate on the high side. So if they say 120 days, maybe they take all 120 days, but maybe it gets done in 60. But they're going to give you usually the worst case scenario. And so you do need to plan for your credentialing process to take as long as the insurance carrier tells you it will take. So don't, if the insurance carrier says 120 days, don't think, well, maybe, I'll get it in 60 days. It's probably not going to happen. And if you're missing information or you provide incorrect information that causes your application to be rejected or delayed, that can extend the processing time significantly. So again, providers, do your due diligence with your credentialing specialists, work hand in hand with them to make sure they are receiving all the information they need to send in a complete and accurate application on your behalf. What will my effective date be that I'm considered to be a network? So this is a great question. The doctors will ask me, well, once I submit the application, am I considered to be a network from the day they receive the application or from the day they complete the credentialing and contracting? How does that work? And the answer to that is it depends. Each carrier has its own rules. So what you need to do is you need to contact the individual carrier to determine how the effective date of credentialing is going to work. Is it going to be from the date the application is received? Now, I can tell you that Medicare Part B is generally effective from the date the application is received, and they may even give you 30 days prior to, if you've already been seeing Medicare patients, which you shouldn't have been, but from the date the application is received. Sometimes you may decide, find out, like for example, and this isn't normal, but it does happen. You may be treating patients who all of a sudden change insurance plans. Their employer changes insurance plans, and you don't find out about it until 2 or 3 months into the year, because that's the first time you see a patient from that employer. Now you find out that you're out of network, so you contact the new insurance company or the new contract of the old insurance company that you're already credentialed with, and you say, look, we didn't know that this employer changed. We want to be contracted, but we want to backdate it to the first day of the contract, or the first day we saw a patient under this new contract. And so you can request that. Sometimes they will backdate that for you, and sometimes they won't, but you can call and ask. From the date the credentialing app, or your credentialing effective date could be from the date they have completed the credentialing process and have now approved you as an in-network doctor. So it could be that you apply and you don't get approved to be an in-network provider for up to 90 to 120 days, or maybe even longer. And what will happen is you're going to receive notification of approval, and on that notification you'll have an effective date. Now, if you've already been seeing patients prior to that effective date, you have to know that those visits will be processed at the out-of-network rates and benefit structure. So anything that you have done as far as patient care prior to the effective date of your contracting will be processed out of network. So maybe no benefits at all, maybe a reduced benefit. If you see patients while you're in the credentialing process, it would behoove you to notify the patient that their visit may be processed out of network. And it may behoove you, if you see patients while you're in the credentialing process and you're not sure of what the effective date is going to be, to consider holding off on billing out the claims until you receive confirmation of the effective date from the carrier. So you could tell the patient, you know, we're going to see you. We think today, we'll see you today for this visit. We think we're in the process of being credentialed with Blue Cross Blue Shield. We feel like the credentialing will be effective for this particular visit, but we're not going to know for 60 to 90 days. So we're not going to bill Blue Cross until we know for sure whether this is going to be an in or out of network claim. Because if we process it now and they process it out of network and then later on credential us with an effective date, then we're going to end up having to reprocess this claim. So rather than go through all of that, we're just going to hold off on the billing. So don't expect to receive anything from the insurance company until we have completed the credentialing process. And you may want to notify your patients of that and ask them to be patient with you while you go through the credentialing process. Once you have filled out a credentialing application, then the follow-up on that is going to be imperative. And, you know, sometimes providers will ask me, well, you know, how long does the credentialing process take? And I will tell them that it takes, you know, typically an hour or so for the application itself, but it may be a fairly lengthy process. There may be multiple hours of follow-up if the application doesn't go through, if we're having to redo the application because of incorrect information, if they lose the application. So the follow-up, we never know how long that's going to take. But there are some things that as a credentialing specialist, you're going to want to make sure you do for new applications or updates or revalidations on your credentialing. Number one is, if you do the credentialing application or the update or the revalidation online, make sure you obtain electronic confirmation and a tracking number for your online application. Send that to your provider so they know that it was done. Within 7 business days of submitting the application, contact the insurance carrier to confirm that they have received it and find out when they are going to begin the credentialing process. This goes for applications by mail or online applications. Find out how long it's going to take to process and when that you can expect the effective date of credentialing to be. Is it going to be based on the date they received it and started the credentialing process, or the date they complete the credentialing process? Make sure you respond to requests for additional information immediately. Now, with that said, that means that as a credentialing specialist, it's very important that the point of contact for the credentialing application is you and not the doctor's office or the doctor, because they may miss a key request and not send that to you. So be sure to list yourself as the primary point of contact for that credentialing application that you're submitting, okay? And your own personal email address. And if you have your own fax number, give them your fax number, because then if something is missing, it will come directly to you and you can follow up on it promptly. Contact the carrier for updates to applications about every 2 weeks. Now, I say that, but if the carrier says, look, we have a 90-day backlog and we're not even going to start this application or credentialing this application for 45 days, then make it, calendar 45 days. You'll get the same answer if you ask them again in 2 weeks. So make sure you have some type of a calendar, a reminder, a tickler system to remind you as to when you need to follow up on all of these contracts. The devil is in the details, and you don't want to miss a key deadline. Notify your provider of any information you may need from them in writing. Don't just call your provider up and say, hey, can you send me a copy of your license, or your DEA license, or your updated, your license to practice expired in your CAQH database, and we need an updated license and a new expiration date. Don't do that on the phone. Make sure you have everything in writing and make sure that it is responded to. And if you have not received what you need within 3 to 5 business days, get back on the internet, get on an email and send them an email. This way, you are covering yourself in the event that an application is rejected due to non-submission of information or an incomplete application. Because I will tell you that if you submit an application and you do not submit the requested information in a timely manner, and many carriers will close that application out within 14 to 30 days of requesting that additional information from you. And so I cannot tell you how timely and important it is to follow up on requests for information. As a credentialing specialist and as a provider who is being asked for additional information, I know it's a pain, but everything you procrastinate on just increases the possibility that your application will be rejected and you have to start all over again from scratch. They won't save anything if they reject the application outright, and you'll just have to start all over again. Okay, so this basically concludes our training session on credentialing, the ins and outs of credentialing and credentialing applications, how to do them and how to follow up on them. Obviously, any questions, additional questions, can be directed to me. Again, my name is Lisa Majeski. I'm your instructor and facilitator today. I'm the president of Gold Star Medical Business Services. We are a full-service medical billing, medical consulting, and compliance auditing organization. We also do provider credentialing on behalf of providers. And so if you need these services, you may call me at any time. My direct number is area code 325-942-5656. Again, that's 325-942-5656. My email address is goldstarmedical@msn.com. And I do believe that I have all of my information posted on the very first slide of this handout or this presentation. And so you can reach me on my cell. You can also check us out online at www.goldstarmedical.net. Thank you for your time. Thank you for listening to this very important presentation on credentialing and contracting for providers. Have a great day, and God bless.